Good morning, everyone. We'll be continuing with the remaining cases of blood culture over the last 2 weeks. The first case, we have a 61-year-old male who presents with fever which is intermittent, associated with chills and rigor, relieved on taking paracetamol. Also has yellow discoloration of skin and sclera, pain abdomen and vomiting. All these symptoms are there for the last 10 days. He's being admitted to the hospital for the complaint of shortness of breath for the last 1 day. He's a known case of diabetes, hypertension and CAD post-CABG. He is diagnosed to have bilateral pyelonephritis, acute kidney injury and acute liver injury in July and August of this year. This patient got admitted here on the 19th of December. So on the blood culture which was sent on the 19th of December, we grew Escherichia coli which had ESBL production and also AIIMS production. So it was a paired blood culture and both the samples grew the same isolate. So the patient was admitted on 19th and due to unavailability of beds, patient wanted to get discharged, went on LAMA on the 20th, so he couldn't get this report on the 22nd. So this is the report which we have generated. The corresponding urine culture of the patient also grew the same organism with the same resistance pattern. The patient was actually started empirically on piperazine tazobactam. The urine CUE shows presence of pus cells and the complete blood count also shows elevated TLCs which is neutrophilic. So now we track back to August of this year where the patient grew the same organism in his urine culture with a significant CUV having pus cells and having a similar antibiogram. So during that time, the patient was started on meropenem and doxycycline. So patient was evaluated as acute febrile illness with thrombocytopenia and started on both these agents. Before getting admitted to our institute, he also received a course of injection amikacin. So now in this setting, patient has received 4 different antibiotics. The Escherichia coli, which was isolated in the month of August, continues to be isolated again in the month of December, both from blood and urine, and we've got multiple isolations from our blood sample. So the investigations done in the prior months of July and August support the same. All other tests having the tropical fever panel to rule out other tropical infections turned out to be unremarkable. The serum procal of the patient during that time was elevated. So here you are able to see the NCCT KUB done at that time had bilateral kidney, showed perirenal fat stranding with mild perirenal facial thickening. This is the image of that. You are able to see around the perirenal plane, you are able to see fat stranding, which is a non-specific sign of pyelonephritis. So perinephric fat stranding means that there is a linear hazy streaks of edema in the fatty tissue surrounding the kidney, indicating inflammation or infection. It is often due to fluid buildup from the lymphatic or venous congestion. So this case is an ideal case to discuss our MERINO 1 and 2 trials because both the agents BLBL, piperazine tazobactam and meropenem have been used to treat this case. So we'll just brush up on these trials as we before we go to the next case. So in MERINO 1 trial, piperazine tazobactam and meropenem were both compared in patients having at least one blood culture positive with E. coli or Klebsiella for ceftriaxone or cefotaxime non-susceptible isolates. So we have the primary outcome which supports the use of meropenem in this case. But what are the criticisms of this trial? Is that extended or continuous infusion data is not available. There's disparity between the severity of illnesses. The testing, AST testing method for piptas was only the gradient testing method was used, and the reference method of BMD wasn't used, and many also co-harbored narrow spectrum oxacinase like BLA OXA1 and other ESBL. So when subsequent post hoc reanalysis was done, there was attenuation of the effect of mortality with respect to the piperacillin tazobactam arm. So this is that post hoc analysis which was done. So here these are the blue boxes are the wins for piperacillin tazobactam, and the red boxes are the wins for meropenem. So here this win ratio is nothing but if you take a win ratio, say piperacillin wins divided by meropenem wins. So the problem here is we have more than 75% of the isolates for all our composite outcomes which are tied for both piperacillin tazobactam and meropenem. So in this win ratio, win odds ratio, what they do is they equally divide the ties between the piperacillin tazobactam arm and meropenem arm. So even after doing that, this post hoc analysis is coming in favor of meropenem for the above said indication. So still meropenem is being favored, and 73.4 patients had tied results. So coming to MERINO 2 trial, which was for chromosomal AMC producers, here the important thing is that in contrast to the other meropenem MERINO 1 trial, 0% versus 9% of microbiological relapses were seen in piptas versus meropenem arms. So the microbiological relapses were more in our meropenem arm. I have specifically added this slide to state that we have seen the same case, same result in our case as well. Treated in August with meropenem, we've got a relapse in December. But the point favoring meropenem would be that microbiological failure is less with the meropenem arm.
Is it the same same strain or different strain? This relapse.
Sir, the antibiogram is same, sir.
Antibiogram is same.
Cefepime alone was SDD.
You not check the strain clonality.
Yes, sir.
Just on the basis of antibiogram, we are suspecting the same strain.
Cefepime was SDD.
Last two sentences are contrasting in a.
Yes, sir. So microbiological failure, that is laboratory, like test of cure, we are not able to, it is supporting the meropenem group, sir. Microbiological clearance is better with meropenem group, whereas relapses rate are better with the piptas group, sir.
And they are not seen for Cefepime.
So Cefepime in our isolate, sir, in August it was SDD, sir.
No, this study.
This study they have not seen.
This study is for co-producers or only AMC?
AMC beta lactamase, sir. In this BLA CMY2, DHA17, CMH3 and ACT17 were the most common AMC genes, sir. No ESBL, OXA or other carbon genes were detected in this MERINO 2, sir.
So probably they might be suspecting that most of the isolates in any case would be co-producers. So if they are co-producers, in any case, Cefepime will not be useful. Or if even if it is a moderate producer, so if the MIC of Cefepime goes to 1, in any case you can't use it.
What is the study population here? Number.
Sir, in MERINO it was in MERINO 2 it was in double digits only, sir.
Sure.
So the conclusion of MERINO 1 tells us that piperacillin tazobactam compared with meropenem did not result in a non-inferior 30-day mortality, so that is why they had to stop it in between. Whereas when it comes to AMC producers in MERINO 2 trials, we are able to see fewer microbiological relapses with piperacillin tazobactam. Coming to our second case, we have a 7-year-old male who presents with cough, cold for 10 days, loose stools for the last 2 days. Cold and cough is associated with greenish expectoration, it's not foul swelling, it's not blood stained. Loose stools 4 to 5 episodes per day for the last 2 days. No history of breathlessness, no increased work of breathing, no vomiting, no abdominal pain, and patient didn't have fever also. There's history of decreased oral intake. Significant past history is that last year he had cervical tuberculosis. He was treated with the ATT for 6 months. The documentation wasn't available for that. The patient is immunized as per the national immunization schedule up to 5 years of age and has a BCG scar as well.
Senior male?
Sir?
Senior male as in neck cervical?
Neck cervical.
Okay.
Male patient. So the blood culture sample sent on the 23rd of December grew Salmonella typhi, which is susceptible to ceftriaxone and intermediate to ciprofloxacin. Cefixim was also susceptible. So the other investigations for this patient are here, the CBC and the other tests. Manto gave a 10 mm induration after 48 hours. The sputum TrueNat, which was done, MTB wasn't detected. So this boy is 30 kilos of weight. He didn't have fever in this case. Antibiotics he received were injection ceftriaxone 1 gram IV BD for 7 days. Then on discharge, tablet cefixim 200 mg per oral BD for another 10 days. So in this case, have we adequately treated the boy or have we underdosed or overdosed? So for this, you have to go through this standard treatment document from 2022 from Indian Academy of Pediatrics. So here we have the first line agents and the empirical agents for enteric fever, and the dosing regimen is also given. For ceftriaxone it is 100 mg per kg per day, and for cefixim it is 20 mg per kg per day. So in this case, instead of 1 gram BD, we should have given 1.5 gram BD, and cefixim instead of 200 mg BD, better to have given 200 mg TDS, considering the fact the boy is 30 kilos of age, 30 kilos of weight.
OPD case IPD?
So patient was admitted IPD and then managed. Cefixim was for the IV to oral switch. So here the duration of treatment for enteric fever according to this guideline is that treat for at least 7 days after defervescence or a total of 14 days, whichever is later. So that is the duration. So this is another guideline from the BIA, British Infection Association. This gives us various classifications for MDR enteric fever, XDR and ESBL enteric fever. So when should dual antimicrobial therapy used in enteric fever? So we see a lot of cases where they treat with cefixim plus azithromycin. So they usually say cefixim is more a water soluble agent, azithromycin is more a lipid soluble agent, has better intracellular penetration, more lipophilic. If there are any reservoirs, azithromycin will take care of it. But when do we actually give this dual therapy according to this BIA 2022 document? So added empirical therapy of other pathogens such as rickettsia or suspected bacterial sepsis, then we can add. Or if we have to have an anaerobic coverage, this is not just specific to adding azithromycin, it can be with respect to adding agents like meropenem as well. So if you are suspecting anaerobic infections in the setting of any perforation, or if there's any XDR enteric fever, especially us India being a bordering nation to Pakistan, which has reported cases of XDR enteric fever, we have to be cautious about such XDR cases also. So whenever IV therapy or XDR enteric fever is being looked into, we have to give a combination therapy. So coming to another update with respect to enteric fever. So now according to our IAP, at 6 months we give our conjugate vaccine which covers for Salmonella typhi. Now Bharat Biotech along with the University of Maryland, they are coming up with a vaccine, a conjugate vaccine which is trivalent, which also includes 2 other non-typhoidal Salmonella species. So coming to our third case, we have a 53-year-old female with complaints of left lower limb swelling for 1 day associated with pain, decreased sensation of left leg. This No complaints of fever, trauma to the left lower limb or abdominal pain. This venous gangrene of the left lower limb later, and later IVC filter was placed with thrombolysis with the left common iliac vein and left and external iliac vein. The patient had a condition called May-Turner syndrome, for which this venoplasty was done in view of the extensive DVT. So the patient also developed left compartment syndrome, for which fasciotomy was done. Patient is a diabetic and hypertensive. We will see the sequence of events of what happened in the hospital. So a May-Turner syndrome is a vascular condition where the right iliac artery compresses the left iliac vein against the spine. So this causes obstruction of blood flow from the left leg, often causing swelling, pain, changes in the skin, leading to DVT, as we see in this case. Here you are able to see the IVC filter in situ. So the blood culture sent on the 29th of December grew carbapenem resistant Acinetobacter baumannii. On the 27th, they had also sent a tissue sample which had thrombus, which had no growth. The procal during that time was 3.4. The patient's WBC count was also elevated, neutrophilic, platelet count is also decreased, patient had thrombocytopenia. So this is the timeline for the patient in the hospital. When the patient presented with the above said symptoms, an IVC filter was placed via the right common femoral vein puncture, managed with analgesics, and then on 25th the patient developed multiple blisters in the lower limb, for which fasciotomy was done. Patient was treated with again a redundant antibiotic coverage of piperacillin tazobactam and metronidazole. This we have discussed with the respective clinical team, but this seems to be the practice again. So again, the patient had to undergo a left above knee amputation in view of the spreading infection. Patient was still on piperacillin and metronidazole. Then he was transferred to the SICU. As a result of the surgery and blood loss, he was also transfused 2 PRBCs. In the SICU, he had hemodynamic instability and also needed respiratory support. He had to be on vasopressors. He also had low blood, in spite he had low blood pressure and decreased urine output. So on the 29th early morning, the patient desaturated. There was also neurological decline and the patient succumbed. So the cause of death in this case can be due to septic shock, so complication of the severe limb ischemia infection leading to multi-organ failure and cardiac arrest in this case. So in this case, we dispatched the report timely within 2 days on the 31st. But the patient expired 2 days prior to that on the 29th. The sample was sent on 29th during his resuscitation time. So the treatment for this carbapenem resistant Acinetobacter baumannii, we couldn't do that. Since the patient had a procoagulant state, he was already on anticoagulants, so the sudden desaturation could be a cause of a pulmonary thromboembolism, for which test like a CT pulmonary angiogram would be conclusive. But in this case, we are still in the grey area. We are not exactly able to say whether it is, or it could be a combination of both the septic shock and the pulmonary thromboembolism.
What is written in the death note?
Sir, death note they are saying septic shock, sir, but features of volume overload was also there, which can again be a cause of pulmonary thromboembolism.
You can present this case in the morbidity mortality. Discuss with Rakesh.
So this is an article released in the Annals of Intensive Care in this year 2025. They are looking at the outcomes of crab bloodstream infections. So the key findings of this study is that most of the bloodstream infections due to crab, the primary source is from the lungs. The second place belongs to catheter related infections. The 28-day mortality of crab BSA was more than 50%. These cases present with a higher SOFA score colistin based therapy was associated with improved survival only when improved survival outcomes in the time window bias adjusted cohorts. In patients having pneumonia and CRAB BSI, colistin did not fare well because of its PK/PD parameters. In such cases, a sulbactam based regimen improved the survival of those patients. So whenever it is a respiratory source for the CRAB BSI, colistin should not be our first option. In this study again, neither carbapenems nor tigecycline based therapies demonstrated good mortality benefit. So going to our next case, we have a 67-year-old female who's a diabetic hypertensive stage
In
5.
this study, have they mentioned that despite ampicillobactam resistance, does it still fare well?
Sir, it's still
to do a combination therapy with minocycline?
Sir, in spite of ampicillobactam being resistant, if it is combined with minocycline or even polymyxin B for that case, either a double or triple therapy has to be given, sir.
But not colistin.
But not colistin, sir.
Also, they are telling, sir.
Huh?
A combination with high dose miropilam, ampicillobacter with
Ampicillin
high
hydrosmiropilam.
dose
That
miropilam.
27 gram per day regimen.
27 grams is ampicillin.
For ampicillobactam only I'm saying, sir.
Meropenem, 2 grams.
2 grams.
Meropenem 2 grams.
And anything related to polymyxin B or
Sir, in this
inhalational?
sir, inhalation they have not mentioned, sir, because now inhalation most of them are they're going against inhalation because of the bronchospasm.
There are two schools of thoughts actually. Some are telling that bronchospasm will be there, so you should give any bronchodilator along with this one. But some are saying there is no such thing.
Sure.
So coming to our next case, we have a 67-year-old female who's a diabetic and a hypertensive, has stage 5 chronic kidney disease. She has a specific comorbidity in the form of a left radial artery pseudoaneurysm with thrombosis. On December 18, she comes to our hospital with shortness of breath, grade 4, has orthopnea and high grade fever. So all the investigations were sent. She started developing respiratory distress for which she was intubated. She also developed hypotension for which she was started on vasopressors. So this all happened on the same day. So the date of admission and the date of death is the same day. It's on the 18th of December. So the cause of death was a septic shock. The patient couldn't be resuscitated. So the multiple comorbidities of chronic kidney disease, metabolic acidosis and thrombocytopenia would be the associated factors leading to the patient's death. So if you're able to hear the TLC which is sent on the same day, shows an elevated count of 31,000. It's again neutrophilic, 92%. The patient's renal parameters are also deranged. Creatinine is 6.4. Serum procalcitonin is again elevated.
Vitro
Is highly elevated, more than 37,000. Again, patient having cardiogenic shock features, heart failure. So the blood culture sent on 18th grew Staphylococcus aureus. This Staphylococcus aureus is a methicillin susceptible Staphylococcus aureus. So we have suggested anti-staphylococcal penicillins like cloxacillin, dicloxacillin and flucloxacillin.
How come oxacillin is not come here in this report?
So this was the report on that.
Normally in unit entry, whenever do, if we enter cefoxytin as susceptible, by default the printout will come as oxacillin susceptible also. So this M39 protocol of reporting, testing for cefoxytin but reporting for oxacillin is mandatorily fed inside the unit software. So ideally it should have come, so that means during cascading, oxacillin has been removed. So don't remove oxacillin. Alright, when you're doing unit entries, don't remove oxacillin. Put both of them, cefoxytin and oxacillin, both. Alright.
As a result of the short duration of the patient in the hospital, you're not able to exactly get what antibiotic the patient was on, but definitely anti-staphylococcal penicillins or cefazolin wasn't started. Patient wasn't treated for MSSA. So this is an article which compares the clinical characteristics and outcomes between MRSA and MSSA infections in ICUs. So the 7-day mortality was higher with MSSA than MRSA infections. So this is again because of bad AMSP practices where patient is again being continued on vancomycin even when the isolate is an MSSA. So here the independent risk factors which they saw are vascular comorbidities, it's an important thing, and even patients not being sent for a clinical micro and ID referral. So in our case also we had a vascular compromise in this case in addition to chronic kidney disease. One point with respect to MRSA infections is MRSA had a longer ventilatory support period compared to MSSA in this study. Another trial comparing Staphylococcus aureus bacteremia, cloxacillin versus cefazolin. So the drug of choice we usually go for anti-staphylococcal penicillins, but in this trial cefazolin constitutes an alternative to cloxacillin for treatment of MSSA bacteremia, offering non-inferior clinical efficacy and potentially enhanced tolerability. Certain things they have taken in this trial. They have excluded CNS infections because the penetration of cefazolin is not good across the blood-brain barrier, and they have also excluded vascular implants if the patient is having any vascular implants.
You also check for the variability of the P-will expression in MSSA versus MRSA. It's a possibility that could be expressed more in MSSA. That could be one of the causes of high mortality in MSSA.
So addition of
MRSA
clindamycin.
No, MRSA is a survival strategy for the organism. In MSSA there is no such things. So it is likely to be more virulent.
So next. The next case is 60-year-old female who's again hypertensive, type 2 diabetes, and she's been having chronic knee pain for the last 1 year, and she's been using NSAIDs for that. So with this background, early in December she had 12 days before admission she started having abdominal distension. 10 days before admission she had shortness of breath at rest, had bilateral lower limb swelling, dry cough, facial puffiness, dysphagia and decreased urine output. 5 days before getting admitted here she had altered sensorium and irrelevant speech. So she got admitted here the 10th of December. So she presents to our OPD with these symptoms. On examination you are able to see a bilateral pitting, pedal edema, blackish foot discoloration, tense ascites, wheeze is there, crepes are there. So on echo you are able to see a normal LV function, but there is trace pericardial effusion, pleural effusion and ascites is there. Patient is admitted in the HDU. So patient is anemic, is hypoalbuminic, has AKI, hyponatremia, hypokalemia. Again the pro-BNP is elevated, CRP is elevated, procal is not elevated, urine albumin is positive. And on USG abdomen you are able to see cholelithiasis, gross ascites. On NCCT abdomen it confirms the cholelithiasis and ascites. There is no DVT in this patient. Here the patient also has a vascular problem in the form of a severe bilateral posterior tibial artery disease showing no flow. So then we start the patient on ceftriaxone and metronidazole initially in view of aspiration pneumonia. Then it was escalated to meropenem. The patient also in view of anemia was transfused 1 pint of PRBC. So the working diagnosis was aspiration pneumonia, chronic kidney disease, hypoalbuminemia. Patient also had abdominal TB for which she was treated. So this is the CECT chest and abdomen findings showing PAH, left upper lobe consolidation for which treatment was initiated, an atropic right liver lobe and massive ascites and umbilical hernia. The patient again became irresponsive, or she was shifted to the MICU. On day 10 and 11 in the hospital, that is on December 20th, again the second PRBC transfusion was done. She developed an NSTEMI during this period. Patient of course has heart failure. And on 22nd is what she was declared dead because she went into bradycardia, had no pulse, the BP was unrecordable, and again she had an anterior STEMI in this case. blood culture was sent on 19th, right before this, and we reported it exactly on 22nd, maintaining our TAT. So in this case, the blood culture grew Enterococcus faecium. So this Enterococcus faecium was resistant to penicillin and susceptible to vancomycin. So this was the advice given from our side. Patient succumbed before specific treatment for Enterococcus bloodstream infection could have initiated. She initially received ceftriaxone, metronidazole, later got meropenem. So none of these agents would have covered for Enterococcus faecium in this case.
But here the cause of death might not be sepsis.
So here the cause of death is cardiogenic shock and that STEMI.
This is single pure culture or both?
This is single cell. This is.
Maybe contamination. Likelihood of this blackening of leg is presented with blackening of leg also is there.
Sir, that was like long, because of the pedal edema, sir, like long-standing venous ulcer. It was because of that congestion, sir.
Most likely cardiogenic.
So last week we were discussing Enterococcus. We had a case of Enterococcus infectious endocarditis, and during the end of the presentation, Priya was asking me, we have this cotrimoxazole paradox, in vivo, in vitro paradox. So I just wanted to touch on that before we go to the next topic. So cotrimoxazole, as we see in this report, it clearly says don't give these 3 C's in our enterococcal infections: cephalosporins, clindamycin, and cotrimoxazole. Cephalosporins, we have an exception of giving in infectoendocarditis ampicillin plus ceftriaxone a dual beta-lactam coverage to cover both PBB 4 and 5. But in general, as monotherapy, we don't give. So why cotrimoxazole? Why is this cotrimoxazole a paradox when it comes to in vitro versus in vivo? In vivo, we are not supposed to give. In vitro, what happens? So in vitro, we use Enterococcus faecalis QC strain 80cc 29212 as a reference strain for our Muller-Hinton-Agar Kirby-Boyer disc diffusion testing. So the disc of choice there is a trimethoprim sulfamethoxazole. So the main thing here to check is if there is any additional contamination with arthimidin or thiamine. So it is used as a system control and not a treatment recommendation. So in MHA, your thymidine is free. So the bacteria cannot bypass your sulfamethoxazole's folate blockade. So what is actually your this folate pathway? So cotrimoxazole is a sequential blocker of our bacterial folate synthesis. So sulfamethoxazole will inhibit your dihydroapterate synthase. So that will block the synthesis of a dihydrofolic acid. Whereas trimethoprim, it will block your dihydrofolate reductase. It blocks the conversion to tetrahydrofolate. So the bacteria cannot produce its own deoxythymidine monophosphate, which is again a vital building block. In vivo, what happens is, why can't you give this? Because your body itself, as a degradation product, will produce a lot of this thymine. So with the help of this extra thymine, even if cotrimoxazole is going to block that specific enzyme, with the help of this extra thymine, the pathway is going to get completed. So in vitro, it is going to give us a big zone because there is not going to be any thymine. Usually when this thymine contamination happens is when there are traces of blood. In certain Muller-Hinton-Agars, we may have to add blood. So when traces of blood are there, it can cause a decrease in the size of the zone because the bacteria cannot utilize it. So that is the main reason behind this in vitro and in vivo paradox. So coming to our next case, this is a case of a 36-year-old female who's having fever for 15 days. Even yesterday she came to our OPD. It's intermittent. It is recorded at a maximum of 103 degree Fahrenheit, associated with chills and rigor, relieved on taking paracetamol. Patient also had loose stools for 4 days, watery and not blood stained. 4 episodes per day, had headache for 2 days, vomiting for 2 days, 4 episodes per day. The organism isolated was Aerococcus viridans. Treated, it was not treated. It was considered to be a contaminant. A paired blood culture sample is requested. On examination, the patient didn't have any murmur as such. The patient's blood counts were normal. Other tropical panel was normal. CRPs and ESR were elevated. A 2D echo and ANA for this patient is awaited. Liver enzymes were elevated. The ALT, AST, ALP and GGT were elevated. Patient has received 3 antibiotics till now. Doxycycline, metronidazole was given earlier, and now she is on cefixime. She continues to have fever. Yesterday we have sent a repeat blood culture, sir. So we'll follow up this patient, sir.
Right.
So last week we saw a de novo score, and which is a scoring system for enterococcal bacteremia, where if you are not able to do a transesophageal echocardiography with the help of de novo score, if it is more than 3, you can say that the patient has a valvular lesion is there, maybe having infective endocarditis. So a similar score for other streptococci, this is your viridans group of streptococci, is called Handock score. So here the parameters will be your heart murmur, etiology of isolating streptococcal species of viridans origin, a number of positive blood cultures, more than 1, the duration of symptoms more than 7, only 1 species repeatedly isolating the same species, that is O, and C from a community acquired background. So this is Handock. So this Handock can also be extrapolated for Aerococcus viridans according to a few articles. So this is with respect to this case. Coming to our next case, again this is a contaminant. We have grown Viscera confusa from 1 blood culture sample. This patient is a 28-year-old male having a 15-day history of central abdominal pain. He's diagnosed to have superior mesenteric vein and portal vein thrombosis. So because of this gastrointestinal pathology, there is a possibility that this lactobacilli, Viscera confusa being a lactobacilli, would have been translocated from the gut into the bloodstream. The counts are normal, procal is normal, CRP is elevated because of the SMV inflammation there. The patient is having mesenteric ischemia. The APTT was deranged in this patient, so accordingly this prompt switch from low molecular weight heparin to IV heparin infusion to achieve therapeutic anticoagulation. So we come to the end of our cases. So yesterday when we were discussing about these cases, I came across an article again released end of 2024, which has a list of all the recent clinical trials which are ongoing specifically for bloodstream infection. Since ours is a bloodstream infection seminar, I thought I'll come up with the name of these trials. So this has been done by our ECMID group, specific ECMID group, ECMID study group for bloodstream infections, endocarditis and sepsis. So the trials here are FAST trial. Your FAST trial is going to compare your gram-negative bloodstream infections, standard of care AST versus your reveal AST. So it's more like a direct blood culture, that is directly from the blood culture. You are going to compare it with your standard of care. Then you have your SNAP trial, which yesterday again Dev sir had taught us. So Staphylococcus aureus network adaptive platform trial. So here they try to use a DOOR strategy. DOOR strategy is desirability of outcome ranking. So it is again a composite strategy where they are going to use where they will be looking at Staphylococcus aureus bloodstream infections. Then we have intense trial. Intense trial is for again Enterococcus faecalis and faecium bacteria, where they will be looking at a 7-day antibiotic regimen versus a 14-day antibiotic regimen for bacteremia. So these are the dates where the trial is planned to get completed. Then you have game changer trial. This is again for gram-negative bloodstream infection, which is healthcare associated, where cefiderocol is compared against the best available therapy. Then you have a trial for candidemia. We have this new antifungal agent, fosmanogepix. It has an interesting mechanism of action in that it is actually a prodrug, gets converted to manogepix. This manogepix works by inhibiting specifically fungal specific enzyme called GWT1. So this is essential for biosynthesis of our GPIs. We must have heard our glycophosphatidylenoacetal anchors, which are on the surface of the fungal cell. So these anchors are needed to attach manoproteins to the fungal cell wall. Manoproteins are component of the fungal cell wall. So this antifungal is going to interfere with that. Then we have shortened trial, which is again bloodstream infection due to Pseudomonas aeruginosa. Here they are checking the duration 7 versus a 14-day treatment. Then we have INVEST trial, which is for clinically stable non-critical patients with gram-negative bacteremia, where they are going to look at an early step down to oral antibiotics for index blood culture versus continuing IV therapy at least for 24 hours post randomization. So these are the various trials which are ongoing with respect to bloodstream infection as given by ESGBIES. Thank you.